on Zoom. We're all over the place. Right, let's do that. Let everyone check in. Hey there, guys. Jonathan, Morpheus, Robbie, Brad, how you doing? Good to see you guys. And Harm Honey, how you doing? So, yeah, I think we are all on. Recording so that other people can see. And then are we over? We're somewhere over on Facebook. For some reason I can't ever see Facebook, but there you go. We're on Instagram. Hi, Errol. Good to have you along again from India. How you doing, Paul? Brilliant. Yeah, good to see you guys. See you. Kirsty, hi. So we'll just give it another 3 minutes before I start. That'll give you the opportunity to post any questions that you may have. She's back. How you doing? You all right? So any questions you've got. So this is a Biomechanics Q&A. If you haven't been here before, my name is Rachel France. Oh, hi there, Mel. How you doing? So we've got Mel from Amazon Fitness, my fellow, and Kerry. How you doing? So Mel is a fellow Her Spirit coach, which is an app where we provide inclusive, I was going to say entertainment then, Mel, inclusive classes, an inclusive environment where we do live classes, there's recorded sessions. So if anybody's interested, there is a subscription fee for the year. However, you get full access to fully qualified, very well-trained bunch of coaches through classes. So you can go and check that one out. Bit of a plug there. We've got Kerry from right up in the north. How you doing, lovely? See you soon. Murray Sports, Robbie, hi guys. So, yeah, as usual, yeah, me too, Robbie. Just post any questions you've got, guys. I have got a little series of questions, actually quite a few coming through from you, Fee, that I have been asked in advance that I've prepared that I'm going to go through. But it is a live Q&A, so if you can bear with me, I'm on 3 platforms. I will keep checking in and just see whether we do have any extra questions added in. We're going to go for about, I try and do an hour. It normally goes to a bit longer, but I need to finish earlier today because I have another appointment at 1 o'clock and then another one at 2. So it is just an hour. I'm afraid of my voice. You can tune in, tune out, entirely up to you. I really don't mind. We've been doing this through the whole of lockdown. And the purpose of it really is just to, while people have had a bit of time, I've been getting a lot of questions. I get a lot of the same question or the same types of questions come through. So I felt that if we just did this live, then rather than me spending time replying to individuals, I could potentially answer a lot of questions or common types of questions to everyone and hopefully hit a load of people all at the same time. And then I've posted all of these recordings onto the Biomechanics Education YouTube channel. So if this is your first visit, you can head on over, subscribe to the Biomechanics Education YouTube channel. There is a whole plethora of videos in there where I've been giving away free stuff, I'm freely training through testing, some class ideas, there's Q&As, there's interviews with biomechanics coaches, there's a whole bunch of stuff you can go and access on there that we've been trying to help people out during lockdown, where people have had a bit of time, a lot of stress, I think, but I think we're coming out the other side, kind of. But I think what we've now got to get our head around is what is going to be our kind of situation now coming out when working with clients who may have physical issues, ailments, niggles, etc. So the aim of this session is go through these common questions, and I've got 1, 2, 3, 4 questions. So I'm going to run through them, come back with a response. Feel free to challenge or respond. Now, the only platform I cannot see questions on, for some reason, I don't know why this is on Facebook. So if you're on Facebook, forgive me, I cannot see your questions. I don't know why. So if anyone can enlighten me in the meantime. However, Instagram and Zoom, I can see all of you guys. Hi, Omar. Great to have you along. So the first question. Now, this is usually the most common question I get asked, or the problem or frustration of learners who come along into my classroom. And it's, how can I remember the anatomy more easily? So as personal trainers, as Group X instructors, manual therapists, we go through an anatomy and physiology exam. It's usually, for most people, rather stressful. And I think we come out the other side and we just kind of forget it all. Am I right? Is that you? Yeah. So it's very rare that you will stand in a personal training session and talk to Barry about his pectineus or his vastus medialis. He won't know what you're talking about. So it's like when you learn a foreign language, maybe like if you think about French or German that you learn at school, the anatomy is a little like that. If you don't practice it, you forget it and lose it. And then when we're talking to our clinician colleagues who all remember it, we feel inferior, we feel like we're lacking, we lose confidence. And also when we're looking at clients moving and we see problems or issues and they talk to us about, got this niggly shoulder, I wish I knew the anatomy more. So to answer that question, how can I remember the anatomy more easily? And people often have a perception that I have an uncanny ability to remember the anatomy. I don't. I am no different to anybody else, but the way I remember it is I teach it. I teach it on a daily basis. I have my friend around all the time, and when I get asked questions like some of the ones I've been asked today, I go and do my research. So I'm going to have a little look through, I check out that muscle, the one it relates to, how it is involved in movement. And by going through the process of revisiting it, finding, I think, a way of linking it to something meaningful. So if you've ever had an injury, or if a client has had a specific injury or condition, I'm confident that you would have gone and you'd have done a bit of research. So I busted my ACL back in 2009, and I did a whole stack of research around knee biomechanics, ACLs, people who live with them, without them, what happens with the surgery, the options of research. So I know all about, or I know a little bit about ACL, which is the anterior cruciate ligament. So it crosses with the PCL, the posterior cruciate ligament in the knee. And it's one of the 5 ligaments that help stabilize and control the knee. And I am missing that in my left side. So I did all my research, so I know a little bit about that. And I think once you can attach anatomy into your thinking and connect it to a particular person, a particular problem or injury, or come across something. So when you have a question around anatomy or anything like that, set a little bit of time aside, focus on that, research that, use the internet, look in your books, find ways of kind of almost memorizing a problem and how it links to that anatomy. And then when you relay it back to your client, more often than not, that part of teaching it all over again, that's a second round of memorizing. What happens is you start to connect the memory of that particular anatomy, like in my case, the ACL, with other things around stability, around movement, around pain, problems, surgery, acknowledging the things that you might go through, so that I can then give confidence to a client about my experience when they've heard somebody else had a bad experience. So I think how to remember the anatomy is teach it. Teach it is the quickest way, because if you're going to be in front of an audience on Facebook, Instagram and Zoom, and you're going to talk about a particular anatomy, you're going to do your homework. Because if somebody asks you a question, you're going to have to go, oh, I've got to find an answer. I think just to kind of add on to that, I don't think we should feel like we should know it all. And I think it needs to be okay to say, I have no idea. That is not a muscle I'm familiar with. Or that is not an area of the body that I've looked at in great detail. But I will go away, I will look at it, and I will find out. We should also acknowledge that there's these hundreds of muscles, there's all these joints, ligaments and bones, they all interact in a variety of ways and a variety of variables: genetics, previous history, you know, injury, etc., sport, ability, level, and so on. And so it can seem very complex, and in many ways it is. But if we simplify it down, rather than trying to remember all the muscles in a short space of time, focus on areas of the body or single muscles, joints, etc. Find a way of attaching it to a memory, whether that be a particular client. So Barry, who had a disc issue, or Sarah, who had an ACL rupture, and then so on and so forth. And you will start to then kind of tag your memory onto that anatomy, and you'll recall it more easily. So one thing to say is, nobody knows everything about the body. I've been in the cadaver labs on 6 occasions, and the people who are in there teaching our surgeons would even have to go and look in a book sometimes when we asked us a question. Also, the fact we're so different on the inside to what the books show us. So the books will show us in 2D the norms or the averages. And so one of the areas of the body that I want to talk about today, Palmaris Longus for harm honey, when you look at certain anatomy and certain muscles, they can actually be missing in some people. And this is where we start to look at evolution, and we look back into our ancestors and the way we've developed and so on. So the books are very simplistic, and they're a start point. Some books will tell you the generic information. So most books would tell you Piriformis, for example, is an external rotator. It's quite rare that you see it described as an internal rotator, which it is once you change the angle of the hip. So we may not come across those ideas in our study. So when we do come across them and somebody says it's an internal rotator, we say, how is that? It can't be. In all the books it says it's a time of opportunity to go and explore that muscle, find out where that information came from, go and have a read of it, and then you will remember it, or you're more likely to remember it. So that's just from my experience. That's the way I've learned, is literally when teaching. When I'm teaching and I get asked a question, I feel I have a certain degree of responsibility to have a response, either by my understanding of that particular part of the anatomy, or to say, look, do you know what, I've got no idea, but I'm going to find out. In fact, let's get the book out. And I will go with my learners and we'll get the books out, and I'll say, let's have a look. Oh, right, okay, it goes from here to here. So what do you think? And we discuss that particular area, joint, bone, muscle, ligament, etc. So to Jenny, how can I remember the anatomy more easily? That would be my response. Just a little plug for my friend Pete Banbury, who has designed, he's known as the Body Mapper. And I spoke to him just this week about his new online anatomy training that he's bringing out. So you can go and you can internet search the Body Mapper, and he has a very unique and fantastic way of educating us on the anatomy using all the senses, so see, feel, move, etc. So go and check out the Body Mapper. Let him know I sent you over, and he will definitely look after you. He's a really cool, knowledgeable guy. So I hope that helps. Just checking in, see, I'll just check in whether I've got any questions from Harm Honey. Not yet, so I'll just open my chat box, Harm. So if you want to answer it, ask me anything in there. I'm going to get to your questions in a moment. So I'm just going to check in, see if we've got any questions. On Instagram, hey there guys, just have a little look through. I like learning, but I agree with you, won't you? Yeah, you've got to use it, Paul. And the fact that you're here every week challenging me shows. Paul, I like helping people, which is why I started my course after many years of helping people in gyms, and this helps me to learn. Yeah, exactly. So Paul actually hits on the idea that we really want to help our clients. So coming from a place of knowledge to give them information in itself can really help a client feel that you've got their back, that they're being looked after. So it's a really good point that you raise, Paul. So just checking through, see if we've got any other questions coming in based on that. Oops. I have fingers the size of, oh, hang on. There we go. Hey up, Mark. Good to have you in. Nice to see your haircut, by the way. I like the transformation. Right, okay. No more questions down there. Okay, the next question is, if the hip joints feel clunky or poppy, even with small rotations, is this a problem? What is happening inside the body? Now, this is another common question, popping of joints. Now, I have this in my left hip in the front, and if I lie on my back and I lift my legs up, my right hip is fine. My left one, when I bring it back down, I get like a clunk over. So, number one, if it doesn't hurt, don't worry about it. Number two, from my understanding, when I've looked at this, different responses from clinicians and movement specialists, a common thing that can happen within the body is that our bones have nodules and bumps and kind of terrain. And when we take our body into certain positions, sometimes soft tissue like ligaments can kind of just pop or slide over a nodule or a condyle, if you like, or a bony area, and give the feeling or the sensation or sometimes the sound of a pop. So my understanding is if it's not uncomfortable, don't worry about it. If it's the same and it happens all the time and you just do that particular position like mine, I've had mine for years, I don't worry about it. The fact that it's in one side and not the other, I think we should acknowledge that there's a good chance many of us are a little bit asymmetrical intrinsically, our design. So if you've ever sort of looked at a skeleton, remember that not this one, they're usually cast off a single individual. This, I'm sure, is not cast off an individual. This will have been designed, obviously, downscaled. But when you get the life-size ones, they're usually cast from a single person, or they're designed from. And they will have anomalies and differences from one side to the other, as I'm sure we do. If you get a chance to get into a cadaver lab, I would definitely explore the differences where you can see different lengths of bony attachments from one hip to the other side, and the knowledge that, well, muscles will attach to that area. So are the muscles actually designed or a different length? Do they attach at the same height with one being lower down towards the bottom, or do they have different lengths in those if the attachment that they land on or the attachment site has a different shape or length? So in terms of if a joint feels clunky or poppy, if that clunkiness feels awkward or uncomfortable, and you haven't had an injury or anything of concern, it could be biomechanical. So it could be that your muscles have adapted to a sitting posture, or if you have an asymmetrical sport, if you're skating around a rink in one direction, maybe over time the body's adapted a little bit and your intrinsic biomechanics are just slightly off, and so you get in this clunk or this pop due to that. Or it could just purely be your geometry and your design means that the soft tissue as you go through a certain movement. For me, it's always exactly the same, lying on the back, lift the leg as it comes down. It's always at that point, and I think I must just have a little pop area where I have a nodule or a bony prominence that the ligaments just pop over. Doesn't hurt, never bothered me, other than, oh, that sounds a bit odd. I've researched it and I've found that it's fine. So as long as you're not uncomfortable with that, I think it's okay. If you're concerned for any reason, obviously go and have some assessments done to check that you're stacked up. Obviously, I know you're doing I'm in freely, and working through the lockdown bundle that we've given you, you'll be able to test your own pelvis and spine a little bit. Anybody else wanting to look at some of the tests that we teach, you can go to, again, the Biomechanics Education YouTube channel and follow the Squat Project, which is a layperson-facing series of 7 videos looking at the pelvis, spine, shoulder, knees and feet, how to test your own body a little bit, and then some techniques to improve your movement. And what might happen over time is you get less clunking, less popping. If you do, great. If it's still there, it doesn't hurt, don't worry about it. So hopefully that answers your question on that one. If not, obviously type away. Oh, let's have a look. Hi there, Saif. Good to have you back. What about muscle memory in rehabilitation, for example? Yeah. So again, when you're talking about rehabilitation, and I think, Saif, are you a physio? What we've got to acknowledge is the pathway from getting injured, seeing a clinician, rehab, and then post-rehab, which is most of us are post-rehab. Because unless anybody out there is a clinician, obviously let me know. Like say, if you are a physiotherapist, do let me know. Then there's a difference in what we might do about it. Yeah, exercise physiology. Okay. So muscle memory, people talk about muscle memory and rehabilitation, and there's also the idea that there's not an exact question in there, Saif, but I think what you're talking about is there might be examples where you have an amputation or an injured leg, and you can work the other side or the upper body, and that has a neural effect on the injured side, if you can use muscle memory to come through rehab, post-rehab. In terms of low-grade muscle energy techniques we use, Saif. So because you haven't got a direct question in there, I'm just talking around it, but let me know. Yes, okay, fantastic. In the process, brilliant. So let's have a little look, just checking if I've got any questions. Hey there, guys, good to see you all in. Boris Jacks, hi. Would love to get a skeleton. Can you advise where I would get one, please? Yeah, definitely. So I get all of my skeleton kit from 66fit. 66fit.com. He is about 83, is it 83 inches? Centimeters, going to be bigger, isn't he? And I get my pelvis, spines, all my little bony bits. But my full skeleton was, I think, from eBay or Amazon, around about 90 or 100 pounds shipped over from Germany. Leanne, just started my journey finding your classes when I realized they're on interesting and taking info in as learning. Thanks. These are great results. Oh, you're welcome, Leanne. Thank you for that feedback. So much appreciated, and ask away if you've got any questions. Okay, so I think we've talked about the poppy clunky hips and joints. So the next question, it wasn't a direct question, however, it was, would like to learn about Piriformis Syndrome and tethered nerves. So these are a common vocabulary that we might come across in our profession, even as exercise professionals. Hi, Nutter Laura. Great, catchy name. I could a tight piriformis, great question, lead to a clicky hip? What would be the best way to deal with tight glutes as I find them hard to stretch? You've just asked the perfect question, Nutter Laura, because it comes straight into what we're going to be talking about here, which is Piriformis Syndrome and tethered nerves. So first of all, what we need to do is define Piriformis Syndrome and then separately define tethered nerves. And then what we can do is kind of pull that apart so that then we can learn about it, which is basically what it's not a direct question, but I've been asked from someone who wants to learn about Piriformis Syndrome. If I was in front of someone who said that to me, I would want to know why they're asking. But what I'm going to do, what I've prepared, is to talk about what they are, define them, and then what that might mean to us. But if I was with a client or an individual, I would want to be asking a whole load of questions around, why are you asking me? So often people ask a question or they say they want to learn about something for a reason. When we know the reason the question's being asked or the point is being made, it enables the response to be more helpful. So if the response I give is not detailed enough, then obviously we can have a conversation if it is more individual to you. Do you have any suggestions on where to get pelvis and spine? I suppose, yes. 66 fit, mate. So Piriformis syndrome. So syndromes are often a kind of a group name for a symptom or a condition. The piriformis muscle is a little muscle in the back of the hip. So for those who may or may not be familiar, it's from the anterior surface, that's the front of the sacrum, which is the lower portion of the spine, just above the coccyx and below the lumbar spine, and the front sort of kind of lateral side of the sacrum. And then that's the wide end, and then it becomes narrower as it comes across onto the greater trochanter, or the top of the femur. So where this band of muscle goes from here to here, it's responsible for predominantly lateral rotation or external rotation of the hip, abduction of the hip, a little bit of extension. And if you bring your hip above 70 to 90, which is debatable in different papers, the piriformis muscle becomes an internal rotator. Now, there's a superb video on YouTube, and I think if you just type into the YouTube search bar, piriformis actions, I think it comes up, and you've got a guy holding a leg, a skeleton, another back guy with a band, and another one holding, and they show how the piriformis muscle, when you flex the hip, the axis, the muscle swaps over the axis point, and so it goes from being a lateral rotator when the hip is extended to an internal rotator when the hip is flexed. So you can go and check out that video just to, if you're like me and you're a visual learner, it's much easier to watch that in action. So the piriformis muscle, and then syndrome, which is often tied to, as I said, a symptom. So piriformis syndrome is sort of synonymous with buttock or hip pain. Now, one of the problems with that definition is pain is subjective and can be, it's an input, not an output. So your bum doesn't hurt. It's your brain is being told by the area of the body that something isn't right. And so root causes can be from different parts of the body. So another resource for you is Explain Pain, which is by Lorimer Moseley. So if you go again to YouTube, you can type in Lorimer Moseley, Lorimermoseley, Explain Pain, and he and David Butler, his colleague, are really leading neuroscientists into the science of pain. They're really good at explaining it, and they make it very lay friendly, so client friendly as well. So pain is subjective. So piriformis syndrome, usually linked to symptoms like buttock or hip pain. Now, several articles, and I've done a little bit of research for this one, several articles will define it as peripheral neuritis, which is an inflammation of the nerves, and it's at the branch of where the sciatic nerve, which it causes like an abnormal condition, like the piriformis muscle might adapt or shift or change, like there's an injury or an irritation. So what does all that mean? Okay, so it hurts here. It could be defined as piriformis syndrome. So what a clinician or somebody might do is move your leg around, ask where and how it hurts if they stick the thumb in or in certain positions to identify the location. What it doesn't tell you necessarily is the root cause. It tells you it hurts here. It might be classified as piriformis syndrome, but what's more important than that is what is causing it. And I want to go into the anatomy a little bit more through the definitions, because I just want to open your eyes and mind up to how wonderful our integrated system is at compensation, and how that can be a big problem when it comes to identifying what's causing what. So whether you're an exercise professional or a clinician, you must be mindful of your remit here. So I'm kind of crossing two insurance brackets. So just be mindful of that. So piriformis diagnosis can only be done by an allied professional or clinician, of which I think there's about 13 titles on the guidelines. So physio, chiro, osteo, GPs, etc. A sports therapist is not qualified to diagnose at degree level even. So we need to be mindful of language and who we're with and what we're looking at, what we're doing. Exercise professionals, manual therapists, like in here, we're not qualified to diagnose at all. So if a client comes to us with a diagnosis of Piriformis syndrome, we must communicate with that clinician to understand their input, everything in writing, follow all the protocol, so that we can get those multidisciplinary approaches coming together. They can guide us on exercise, and we can talk to them about what we might do, and they can say yes or no. So that's super important. So injured or irritated, well, what does that mean? So obviously an injury is where you have trauma, you have an accident, something happens. That usually makes things more obvious. You fell off your bike, you whacked your hip, ow, it hurts, and you've got a diagnosis. However, I think more commonly, and just looking at when I did more research into this, is an irritation. Now, an irritation of your piriformis muscle can be caused by several things. Now, in all the definitions that I researched here, it's very closely linked to the sciatic nerve, which is the bit I want to talk about. However, the sciatic nerve, or the nervous system, is a single continuum through the whole body, which means there is the potential for tension being put upon this area of the body from anywhere else in the body. So I'll go into that in a little bit more detail in a moment, but just to go through kind of research and so on. So I'll try and get evidence-based information for you all. There are 6 categorizations of piriformis and sciatic relationship. That's based on Beaton and Anson. And they list them, the nerve goes under the muscle, over the muscle, through it, round it, and all sorts of orientations. One is classed as the normal orientation, and the other ones are classified differently. So could Piriformis syndrome be linked to one of the abnormal presentations of the anatomy? This is where you get 2 classifications of so you've got the primary and secondary causes of Piriformis syndrome. So primary is an anatomical cause. Now it's fewer than 15% as per the reading that I found, where you get things like a split piriformis or a split sciatic nerve. They sound quite dramatic, don't they? Or an anomalous sciatic nerve path. So that means where it's not following the normal pathway. So what do we take from that? Well, it's understanding that, well, we're all a little bit different on the inside. You can't change your design. So what does that mean when it comes to working with a client with Piriformis syndrome? Well, unless we can see what's going on inside their body, and actually quite often when we can see inside their body, we have no idea if they have an anatomical difference or some anomaly within them that's different to the normal presentation. I don't know if clinicians or professors have ways of testing this, or whether they've only discovered this once you are a cadaver on the lab and they kind of dissect you. I don't know. I'm totally ignorant to that. So if anybody out there can enlighten me, that would be really helpful. But I imagine it will be tricky without going in, chopping you open and having a look. Studies suggest anomalies may not be as important as dysfunction or pathology. So the anomaly of your design is less important. And I think that just comes back to what I was saying. If you can't change it, we don't worry about it. We work with what we've got. Now, the secondary definition of Piriformis syndrome occurs when there is a precipitating cause. So that might be macro trauma, micro trauma, ischemic mass, local ischemia, so inflammation. It could be biomechanical. And so I think if we use our logic and common sense, then there's a good chance that poor lifestyle and biomechanical loading could be a high contributor to Piriformis syndrome. With all of this said, the question is, what do we do about it? So if you or someone you know has been diagnosed with Piriformis syndrome, it may be affecting quality of life. It's uncomfortable to feel discomfort and pain. So what can we do? ultimately we probably want to be taking pressure off that area. So sometimes actually addressing the area itself can be uncomfortable and it holds more risk. So if there's something going on in there, you need to be with a professional who is covered, insured. If they're going to put their hands on you or treat you in any way, it needs to be a qualified and insured clinician. If we're talking about exercise, then because the body is designed as an integrated system, if we get the area of the body above and below moving well, we can actually be taking pressure off that area through reducing tension on the nerves, the muscles, the joints. So by moving well generally and using low-grade simple techniques for someone who's uncomfortable, away from the site of pain, we should be staying within our remit while we work with our clinical friends who may be treating that area. So I've said quite a bit there, so hopefully I've answered quite a bit of that. I've not finished yet. I'm just having a look at if there's any, oh yes. Understanding the pathway of the nervous system. The nervous system is a continuum. So if you have tension or tethering in your nervous system, then we can mobilize it. So tethering or tightness in the nerves is not the same as an impingement. They're two different things. An impingement is clinical. Tethering or tightness is biomechanical. So if somebody has an impingement that can only be diagnosed, again, by a clinician, then they would need to see the clinician for an intervention or treatment or how to reduce that impingement. If it's a tethering and your client has no red flags, you've gone through the protocol, you've done your PAR-Q, they're cleared to move, they just have tightness, they may have tension, tingling, tightness, but nothing extreme. It's just when they put the nervous system onto a stretch, then we can certainly mobilize the nervous system. So tethering is simply, if you imagine that relationship between the muscle and the nerve, and they're very closely linked. If the muscle is dysfunctional, tight, in spasm, whatever, that can affect the movement or the pathway of the nerve and mean it's tethered or tight somewhere. So the nerve might complain, you could get one before the other. It's kind of chicken and egg when it comes to knowing which one's causing which. But if we reduce the tension of the muscle, we can use METs, muscle energy techniques, which I know you've been using, which are very low grade and safe. But we could also at some point start to move the nervous system, but we don't necessarily need to move it in the area on our client that hurts. We need to let the clinicians sort that bit out to stay within our remit. Now I'm being general here. I'm trying to be, give the appropriate information across a blanket of professionals who might be listening to this. So understand your remit when dealing with clients with pain. So Piriformis Syndrome, I think we've talked about, and tethered nerves. If you want to look more at the nervous system, if you go back again to the YouTube channel, Biomechanics Education YouTube channel, I did a session on the nerves in a previous Biomechanics Q&A video, and I think it will say it on the title, so you can go and have a look at that. Or in the squat project, I think video 4 or 5 is again about the nervous system, so you can go back and check those out. So hopefully that helps. Question 4, lumbar spine area strengthening exercises and any tips on decompression of this area. So I think the question was, do you know any lumbar spine strengthening exercises? The fact it was followed by any tips on decompression of this area. So I'll need to address the language first before I can answer it. If you have decompression, if you feel you need decompression in that area, that indicates to me that there is a problem of compression. If there is, then you need to see a clinician. You need to get advice from a qualified professional about the compression as to whether there is any risk. That is number 1. Number 2, having compression in the lower back wouldn't automatically mean it needs strengthening. Now I'm reading between the lines of this question. It's kind of like a statement and then a question, but I'm just surmising because these are common ways I get asked stuff across social media. So lumbar spine area strengthening exercises and then tips on decompression. So I'm reading that person is saying they have compression and they want to strengthen the back. So number one, see the clinician about the compression. Exercises to help this area of the body is going back to what I was talking about. If there is compression in the lumbar spine, then there is a reason why it's been compressed. I would want to understand all of that first. Basic common sense and logic would tell me that that sounds more like a biomechanical loading over time. Unless there was trauma and accident, and then I would imagine that they wouldn't be asking me this question if they was, strapped up in a hospital bed due to a car accident. So I'm going to assume it's not. I'm going to assume it is degradation within the spine area over time. So it's insidious. So that would indicate a good chance that it's a biomechanical loading. So the lumbar spine can be influenced by both ascending force from the feet, the knees and the hips, and descending force from the upper spine, the shoulders and the neck. So any of those areas that may be stiff, problematic, inhibited, I would want to be addressing first to decompress the area safely without messing with the area that is compressed, maybe painful or uncomfortable. So that would be the number one way of looking at it there. And then lumbar spine strengthening exercises, I think, are then relatively obvious. The problem you face is if you have compressed spine, we need to understand what's going on prior to prescribing the most appropriate lumbar spine strengthening exercises. So lumbar spine strengthening is simple. You load the lumbar spine. For somebody with compression, then that may change depending on the load, tissue tolerance, pain, symptoms, risk, etc., etc. So I think I've kind of answered that one. I'm just going to come back down. Saif, it's important that a physio should diagnose. Yes, I think that's the same. Are you over in India, Saif, with some of the other guys? I know we've had quite a few of you guys looking over, and it's knowing that things are the same in any country around the world because they can differ quite often. I'm just going to go down to Instagram and just check in for questions. So, okay. So Nutalora, I had a clicky hip for a while, but I've just started to get pain in the front of my hip. Wondering if it's to do with the piriformis muscle. Nutalora, honestly, no idea. I would need to assess you and go through your history. The fact that you're uncomfortable would indicate to me you would need to have further exploration. It would be inappropriate for me to try and diagnose or give you a suggestion on here, other than everything I've spoken about so far. Jonathan, I work with a few athletes currently, and how would you assess breakdowns and weaknesses which usually happen at high velocity but don't show up in low demand movement patterns? Great question, by the way, Jonathan, and great to have you in there. I've just started working with a GB athlete right now, and I'm being challenged by the strength and conditioning coaches, and there's quite a bit of evidence to suggest that static testing can still be helpful even during high speed. Sorry, let me just reword that. Some static testing can still be helpful to understand your biomechanical setup, even when understanding problems that might occur at high speed. So a common problem at high speed is nerves that are tethered or tight, hate high speed, they hate to be stretched. So in elite sport, I think if you're missing testing the nervous system, you are missing a huge inhibitor of muscle performance and optimization. So that would be my big go-to, just from my limited experience with athletes. But that might incur a bit more of a conversation, Jonathan. But go to the videos I've just described that talk more about the nerves. If you haven't seen those already, they are really simple to understand and test and exercise. They're very complex in the way they function, which is the challenge we face, I think, when it comes to working with clients at high speed. Some of the techniques that we use, like nerve mobilizations, improved spinal velocity by over 200% very quickly. We improved quad strength output by 50% in 10 days of a nerve mobilization. So any of your track guys, is it track guys you're talking about? I know you're a track athlete, but I think with you saying high velocity, that's what I'm assuming. If you're not assessing every joint and structure, then you could be missing the one thing. So it's often thought that tests should mimic the sport. If you think about plantar flexion in running, plantar flexion is the same whether you're running, the action is the same whether you're running, jumping or walking. It's still plantar flexion. The speed, the angles, etc. will change depending on what you're doing. But the actual action itself, so a simple one would be, do you have limited dorsiflexion? And that is going to limit then your ability to plantar flex. So if you've got some kind of limitation around the ankle, you could do a very static test to identify if one of your athletes may be limited in their power production of plantar flexion. So it doesn't necessarily have to be that the test is done. And I'm not sure that's what you're saying, if I'm honest. I'm just trying to talk around common areas, because in athletics there's a lot of research, there's a lot of study, there's a lot of extrinsic biomechanics, and what I specialize in is intrinsic biomechanics, so what's going on the inside. And we really need to understand all of that, irrelevant of the sport, irrelevant of the injury, irrelevant of history. Understand pelvis, spine, shoulder, knees, feet, muscles, bones, nerves in every area of your athlete. If you're not testing everything, you could be missing the missing link. Come and do my diploma, Jonathan. Shameless plug. And I'll teach you how to do that. So Brad tried to explain how the piriformis changes action to my dad, and he couldn't figure it out. Brad, you're a brave man. Leanne, is there any books you can recommend as well as online research regards the anatomy, please? Yes, I'll come to that in a minute. Jonathan, you're very welcome. Yeah, mostly track days. Footballers too. The action. Footballers, hamstring, sciatic nerve. Yeah, very common. So we worked with some of the Premiership football clubs back in the day. Arsenal, Chelsea, Leicester Tigers as well, rugby. So a bunch of those guys, and actually some of the stats I've given you are from that sport. So definitely check it out. Often hamstrings are blamed for issues that relate to actually the nervous system. And the hamstrings are hanging on, trying to protect the nervous system. The hamstrings appear tight. What people often do is strip them, stretch them, and actually not address the nervous system. So check that one out, definitely, for sure. So an anatomy book for Leanne, I think it was, or Leah. Sorry, my apologies. Let me get your name right. Leanne. Trail Guide for the Body by Andrew Beale. Trail Guide for the Body, Andrew Beale. I think he's on like 5th edition or something. It's around about 50 quid, 60 quid on Amazon, and they do a student book. They also do flashcards, but they're aimed at manual therapists, but I do think it's one of the better representations of anatomy, because they show images, for example, of the glutes, and they show the glute max chopped away, so you can see where glute min, and it kind of shows the layers and how to palpate as well. So I like that one. It's one of my faves. Okay, so that was the lumbar spine one. That went off in all directions. Saif, for the foot limit, he could use a foot scan. Yeah, definitely. Make sure center of mass. Yes, I was assuming foot, so I just added that in, Saif, as an example, because I know that Jonathan works with track and footballers, as he just shared. So hi there, Alison. Good to see you. So last question. So Palmaris Longus, I have read that it helps with flexion in the wrist, and also that it has no function whatsoever. So I went on a little learning journey with this particular muscle. So I put up an image on Instagram the other day that inspired this query. So Palmaris Longus. So it is absent, and where I've been reading, some papers say 10%, some say 14, some say 15. So between 10 and 15% of the population do not have a Palmaris Longus. And it varies greatly in different populations. So, looking at different races, some will be more likely to have it, some less likely to have it. So if you go and have a little research, between 10 and 15% won't have one. So in response to it has no function whatsoever, that's probably with the understanding, well, if 10 or 15% of us can live without them, what's its job? And so one of the things I find really fascinating when we read about things like Palmaris Longus being absent in 10 to 15%, psoas minor is absent in a high percentage. What does that mean? It means we are still evolving, which I found fascinating. So we have to kind of almost look back at history. And I put up a foot post the other day where somebody was talking about shoes taking us from being more supinators to pronators, when actually the reverse is what's indicative when you look at fossils of feet, is we were very flat-footed. When you look at our ancestors, the actual arch of the foot is very low in contact from fossils of footprints. So we're still evolving. I think having an appreciation of this as body workers, human movement practitioners is so important, because we will have differences. And so when you come out of PT school and everyone has to put the feet here and have the back here and their arms here when they squat, so that when they don't quite look like that, we think it's us or there's something wrong. We're just evolving and changing, and so understanding all of that. Now, Palmaris longus is a long muscle. Now, it's on the anterior part of the arm. Now, if you put your thumb and forefinger together and you have a little kind of raised area here, that will indicate that you do have a Palmaris longus. It is a flexor of the hand, the wrist, and it will stabilize your elbow when the elbow is extended. So if you do have one, it doesn't work on its own, which is why we can survive without it. It works with a group of muscles, as do all of our parts of our body. You cannot isolate an individual muscle. They generally work with others. And so it's understanding the joint angle, the action, the plane of motion, to understand how much different muscles are involved. And again, that's going to come back to how confident you are about your anatomy knowledge. So this is where you get your trail guide for the body out, look at Andrew Beale's work. You can have a research of a particular muscle, you can go on the internet. There's some great resources. By the way, if you do use the internet, please go to like your PubMeds, go to good resources where you know you're getting great information. Don't just go to one source. Don't simply go to Wikipedia. That can be one source. Go to PubMeds, go to journals, maybe read other people's articles, see where they've referenced from, and that may take you to other great resources. So that's the model I use. So it also innervates with the median nerve, which is, we've just been talking about nerves as well. And the median nerve passes down through the wrist here. So you can see how they're kind of closely linked. And the median nerve passes through the carpal tunnel, which is a tunnel in your wrist. And a common problem that people can have, as we know, is carpal tunnel syndrome, which is where they may get tingly fingers and they get issues from a tight nerve, which can be caused by something in the shoulders, the neck, or the back. It has nothing to do with the wrists. So again, when we talk about these things, it could actually be that we release our tunnel by improving the function of our piriformis. Drop the mic. Because the nervous system has a close relationship with the muscles of the hip. The nervous system goes up through the back, which can be stiff because the hips are stiff, the spine gets stiff, the neck and the brachial plexus here gets stiff. The nerve coming down the arm, the median nerve that relates to the carpal tunnel and the palmar longus, it can all relate through and back. And usually we have combinations of dysfunction. So that sounds quite extreme. In my 16 years of biomechanically assessing people, it really isn't an exaggeration. I have seen foot function change by releasing a muscle in the front of the opposite shoulder. So if you want to learn more about the stuff I teach, then obviously you can go to the website biomechanicseducation.com. We have a whole plethora of online resources now, thanks to lockdown, having some time. So you can go and you can look on the website at all the workshops online. If you really like them and you're in the UK, or if you fancy a trip over to the UK, safe, then you can come over and experience the face-to-face classroom, if not the end of this year, early next year, but fingers crossed from September onwards, we'll be able to do some classroom education, how to test for all of the things or things that can contribute to clunky hips, Piriformis Syndrome, tethered nerves, compressed spines, and finding whether you've got a Palmaris Longus or not. So I think that's everything. Sahib, in muscle biomechanics, there is one important principle saying that if we want to avoid injury, we need to move the bigger mass of muscles than the smaller one. That might be one train of thought. I think we should be confident to challenge everything we're told, Sahib, and understand simplistic logic, read around things that we're told. But I think we need to have permission to always challenge what we read and write about. Otherwise, we would not evolve and find out new things. It's always those who do the disrupting that find out the new information. So I'm just going to come down to Instagram. How are we doing down here? Let's have a look. You're very welcome, Leanne. Paul, I love this, as I've had someone say we all have the same origins and insertion points for our muscles, which isn't correct. It isn't, and I can say that confidently because I've been in a cadaver lab 6 times and I've seen cadavers attachments and they are different, very different. Similar. Okay. CC Fitness and Pilates, I miss you live every time as I'm working, but do watch it at a later time. Thank you for these Q&As. Charlotte did day course in London a few years back. Your advice. Oh, you're very welcome. Really interesting. You're very welcome. Okay. Mofo Body Mechanic. Love that name. Okay. So I think I'm going to draw that to a close. I've got an appointment in 7 minutes. So we've got a few more weeks of this free Biomechanics Q&A. You can email me a question at any time and I will add it to the list ready for next Wednesday. Same time, same platforms. You can Zoom, Facebook, if you've asked me questions, I'm sorry I can't see them. I will come to them now and I will try and respond. Instagram, so whatever platform is easiest, I'm trying to hit all of you so that you can all be here together at the same time. So hopefully that all helped. I will see you all on social media, and then if you come and see me face to face from September, that would be awesome. We can do all of this in the classroom. Cheers, Harm. Thanks for the questions, mate. Take care, guys. Have a great day. See you soon. So we'll finish Instagram, download, share. See you soon, Harm. You're very welcome, Saeed. Thanks for coming. Thanks for your questions. Let's do Facebook, stop, and Zoom.